I think we're good. And you sent me something to share, but you texted me?
Yeah, I can. You want me to email it to you?
Hi everyone. We're just working out some stuffs.
You don't have an iPhone, do you?
What's an iPhone?
Okay. So I can't airdrop it to you. I can't conveniently airdrop it to you then. Would you like me to email stuff to you?
Yeah, actually email it to Best Day Fitness and Floats at Gmail. I know it's a lot of letters. Hi everyone. Sorry, we're just taking a minute. Best Day ANDS. We're just getting our ducks in a row. I had a last minute Amazon delivery issue, which kept me from getting our stream set up. So bear with us, folks. All right. Close that out. Close that out. Close that out.
There's one.
All right, we're live there. Let's go to Facebook, get that going, get our Facebooks up. Well, Best Day Fitness, lives. All right. Hey, we're live. Yay. All right, so if anybody has any questions, we'll put them, see them right up here. Right, here. And then we'll do that.
Feels like a Monday, looking like a Thursday. It's Friday Eve.
What? I don't do days anymore.
It's Friday Eve, baby.
People just tell me to show up times and let's see. That's
I emailed them all the images to you.
Yay! We have stuff and things. All right, so while I am receiving that, what are we talking about today, Dr. Tonya?
We're going to be talking about the pain sciences.
So pain is something that occurs in our injured body parts, right? Like if I injure my knee years ago and my knee still hurts, and is it because it's still healing? Or
pain actually happens in your brain.
Pain happens in your brain. I like that. So what do you mean it happens in our brain?
It is, let me find
and I'm going to put some fancy pictures to include in our little presentation today that Dr. Tonya gave us.
I'll send this to you as well. I think that would be ideal. Thank you very much for letting me know that I should have sent that to you already. Let's see, let me download it. Delete draft. I think I already have this, but I just...
Well. All right, we got stuffs and things.
Come on, people. Ask us questions while we're putzing.
All right, there's one image.
There's putzing
we got
happening.
Okay.
Putzing. It's not really putzing because this is actually task oriented. So, Best Day Fitness and Floats.
Yay! Just getting some images loaded up on the screen.
We're gonna do this. I'm so glad you asked me that. Because that's the thing, is I forget the stuff that...
All right, so those are our two images.
There's three. There should be three
there's
images.
One more.
There's cortical smudging.
And then one more.
The homunculus.
Yeah, I love saying that word, homunculus.
So there's Descartes, homunculus, smudging, and the definition of pain are all what have been sent to you.
Cool. All right, so we have... All right, so we got... All right, what is the definition of pain? Let's go over that first.
Let's go ahead and put that one up there. So, pain is, as defined here, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage.
So tissue damage. I picked that out of that. So
pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So this is a complicated and really important topic and definition that anyone who works with anyone who is in pain, especially chronic pain, should really be aware of, because there's a lot of harm that has been caused in the medical world. The traditional medical model, which has, it kind of, okay, I'm going to go on a tangent here. So the pain as the sixth vital sign was a movement that happened, if I'm remembering correctly, somewhere in the 90s. It was the road to hell was paved with good intentions. The intention was to treat pain and to not ignore it or label people as being malingerers, which is something that I was taught how to just determine if somebody was malingering, which is really kind of rude. If somebody comes for you for help and you completely label them in a negative way, judge them and dismiss them. And then it all kind of snowballed into this whole opioid epidemic, because, and it's a complicated conversation. We could have the 47 podcasts on the opioid epidemic and how that all happened. But having pain be the fifth vital sign and looked as something that needs to be medicinally or pharmaceutically treated has created a whole big mess. And so the physical therapy world in particular, since we don't, aside from dry needling, where we do put needles in the skin, we're not able to do invasive procedures, which creates the need for us to be more innovative with regard to how to treat the whole person. And the majority of who a human is what is in between the two ears. And so physical therapists such as Lorimer Moseley, Peter O'Sullivan, Adrienne Lau have led the research in the pain sciences and kind of helped hone this particular definition. And one of the biggest things that has been found through significant research and repeated research is that pain is not, so let's go to the Descartes model. Pain, the Rene Descartes model was that there are, if you see here in this image, the gentleman is holding his foot in the fire so nicely for that moment in time. He's holding his foot in the fire. His foot's in the fire. You can see a nerve that is going from the toes up the leg, travels up the spinal cord to the brain. Mm-hmm. So that old mod, that's an antiquated and proven to be incorrect mod, too simplistic. That the old model was that there are pain receptors that brought pain information from the place where the stimuli occurred up to the brain and told the brain what had just happened. And it's understandable that was kind of where folks came to. But what has been found out definitively and repeatedly through research in the pain sciences and an understanding of the central nervous system. The central nervous system is the spinal cord and the brain. So it's the gray matter that makes up the nervous system. So central nervous system, spine and brain. Is that the central nervous system is actually plastic, meaning it changes with time, it changes in accordance to stimuli, it's very changeable. And so with this neuroplasticity understanding of the central nervous system, somewhere along the lines, we figured out that there are no actual, this photo here, this image here, kind of gives you the thought that the message that there are pain receptors specifically registering pain and then giving that information to the brain. That's been disproven. And so nerves, the new theory is that nerves collect information, they bring it to the brain, and the brain interprets that information. And this is where this definition of pain comes into play, where
so I was always taught like there's nerve receptors that sense like nociceptors are pain receptors.
Nociceptors, yeah.
Yeah. And as I'm learning more, I was kind of thought, or I can understand that they're more like pressure sensors, and your brain is measuring the amount of pressure differential, and that's what's telling you it hurts. What's your thoughts on that? Like,
Yeah, the nociceptor theory is a little bit kind of like this Descartes theory. That's the term. So the spinal cord is actually really complicated. There's multiple tracks. Like if you look at it, it kind of looks like, if you do like a cross section of it, it actually looks like a Mickey Mouse head. But really, for a better way of explaining it, it kind of looks like if you hold a handful of spaghetti. So each like spaghetti noodle, and it's not to scale, is a different nerve track. And so you have a nerve track that collects information related to pain and temperature. You have nerve tracks that collect information or transmit information related to pressure and nociceptors. So nociceptors would be could more easily defined as pressure. But the pressure, it's just information. Gotcha. And so when it, so yes, it used to be thought that the nociceptors were the pain receptors. Now really current pain sciences say there are no pain receptors. And those are a little bit of the renegades who are kind of off on the fringes. And that might eventually be proven completely true, but at the end of the day, the current pain sciences acknowledge that the pain is an experience. It's complicated. It includes the stimuli itself, and then the interpretation in the brain of what that stimuli means, and that is the interpretation happens in the context of a person's past experience with that scenario that they're in, their belief systems, their emotional state. Think about it. How many times have you read an article where somebody was in a car accident and somebody's leg, their ankle was full on broken and cracked over, but they walked home, or they ran to save their buddy and they didn't know their leg was broken because they had all the adrenaline, and that was just a non-issue at the time. They needed to save their platoon or their baby or their whoever it was. They needed to attend to that, and that does have to do with adrenaline and all that, and the pain relieving part of it. But one of those powerful stories or case studies that demonstrates that pain is an interpretive experience that happens primarily in the brain, is, oh man, I should have looked this up. But anyhow, there's a study, you can find it. There's a construction worker in the UK who put a nail, he was using
through his head?
A nail gun, nope. A nail gun through his...
I saw the one through the head.
Right, yes. But now that's a different story about how brain doesn't feel pain because there's no nociceptors in the brain tissue. But yeah, that's creepy too. That's crazy nuts too. But no, he was using a nail gun. The nail went through his foot, through his boot, and he was in absolute agony. They put him in the ambulance. They gave him, he's screaming in pain, writhing in pain, the nail's sticking out of his boot, he's just panicked, and he's a construction worker. These guys are tough. And they get him to and they give him Dilaudid, major pain meds, get him to the emergency room. They do an x-ray because they don't want to take the boot off because they don't want to cause any tissue damage. Yeah. And they realize that the nail had gone between his toes and caused not even a scrape. So he emotionally saw the scenario, and he may have had that happen. He may have nail gunned his hand or his leg or something in the past, and so he saw what he thought what had happened. Now, the first clue should have been that there wasn't blood streaming out of this boot at the scene, now that I think about it. But that's just a really powerful example of how your past experience, your current situation, your interpretation of what is happening, how that informs your brain's response and your response to a situation. And so, of course, the minute he realized that he didn't even have so much as a scrape, he feels sheepish, and the morphine had probably kicked in by then, and he was just on his own little world. But for those of us who work with people who are in chronic pain in particular, it's just a really powerful example of how you're not pain is something that, it's an experience, and it's something that can be modified. It's something that can be reframed. It can be something that can be managed and overcome, or pain should not, it doesn't need to limit your life. And the tissue damage is a whole nother conversation, or we'll talk about that conversation. So that is my favorite, is probably the most powerful story of the interpretation and how the brain how you understand what's happening informs your interpretation of that pain experience. So that's where it says it's an emotional and it's an emotional and sensory experience. Sensory meaning the nerves brought the information to the brain, and then the emotional side of a person. And that's not to say that it's, because there's a book called Explain Pain by Lorimer Moseley, and that came out like in the 90s, and he's one of the leading early researchers in pain sciences. And if you're not careful in the way that that's explained to folks, it can sound like, oh, it's just all in your head. Your experience is not real. Now, that's really an unkind way to explain it to somebody, because that's not, the pain experience is valid and real. That construction worker who thought he had a nail going through his foot was in an agonizing 10 out of 10 pain, and it was appropriate for them to give him the pain medication. This is tangent number 6. This is where that pain rating scale is really misused and misunderstood, and I think there's a lot of patients or people who are injured emotionally, and I speak with people all the time who just really have been harmed by the use of that scale. If a person says that, like when I'm a physical therapist and I'm asking somebody what their level of pain is, it's a subjective pain rating. You cannot compare, I can't compare my 6 to your 6. It's not possible. It's about what if you say you're a 6 out of 10, then you're a 6 out of 10. And if you say you're a 10 out of 10, and I'm evaluating you, and there are no physiological signs that you are 10 out of 10, like you have an increased heart rate, you're sweating, your increased breathing, your increased blood pressure, any of those signs that you're actually in what the definition of a 10 is, because 10 is the worst pain imaginable, we need to call the ambulance. And I've heard people say this to somebody in a really less than kind way. So you need me to call the ambulance then, 10 out of 10? They'll say, and we're really dismissive. And to me, 10 out of 10, when it doesn't appear to be, when they're not physiologically demonstrating what I interpret as a 10 out of 10, that tells me that that person needs their experience to be validated and listened to, and there's more of a subtle message that's being shared in that moment. Hello, darling. What's happening?
Just wanted to give that to Sydney.
Oh, cool.
Thank you.
So let's see, okay. So we talked neuroplasticity, Descartes, the definition of pain, and now I want to kind of jump into homunculus, but are there any questions? Or Chris, do you have anything clarifying that you would like to?
So the pain scale is subjective. You need to listen to what the person's telling you. You don't need to base it on what somebody else's 6 out of 10 is, because everybody's is going to be their own. And it's sensory. The pain is based on all your senses. So
Yeah.
if you see the nail sticking out of your foot, that's a significant oh shit moment.
Yeah, and your past experience.
And
If in that scenario, if you have been injured, and this is also, there's a whole nother overlay here of trauma.
Yeah.
If you have a history of trauma, if you have a history of childhood trauma, or you have a high adverse childhood experience score, you're going to experience and describe pain through a different lens, through a different filter. Where were we on that? Oh yes, so if somebody says to me, and I'm evaluating them, and since I am not a jerk, and I really enjoy my patients, and I'm comfortable with complicated psychosocial situations, partially because of my life experience, but also my clinical experience, which is really varied. If somebody says to me, because it's so interesting, you can see in their mind, like they're scared. There's a YouTube video about this. It's a comedian. He sprained his ankle and he goes to the hospital and he doesn't know what to say. Because technically, the nurses can't give you pain meds unless you say it's more than a 6 out of 10 or higher. But so he's like, well, I know that it has to be like a 6 so I can get my pain meds because this damn hurts. But like, I really think it's kind of more like a 4. But then is she going to believe me? And he goes on this whole big thing. And that's what I can see that happening in the person's mind. I'll say, well, you know, at the best, what do you think? What is your 0 to 10? At the worst, and where are you at now? And when I can see that mental wrangling, then I will do my best to set their mind at ease and say, you know, this is the scale is subjective. And it helps me frame how I'm going to perform the examination. So if your pain is at a 10 out of 10, then I need to be really mindful of not flaring things up. I need to be gentle. I need to be ordering things in a way that I can do the most important things early, and then I can save the things that I don't need to do today for later because I don't want to make you worse. I want this to be an enjoyable experience for you. But if you say to me that it's a 1 out of 10, that tells me that I can order the exam or the evaluation differently. So it's information for me to be able to do my job and do right by you in the best manner possible. And it's your pain rating. And then we can also look back at our charting as we move forward to see how you've improved, because it's your description of how your experience is. And usually when I explain that to people, you can see they exhale and lose 75 pounds off their shoulders. Because for one, I just listened to them. And number two, hopefully I explained it in a way that they understand. And number three, it shows that I'm using that information not to judge them, but to work with them and to do right by them. And so I think that I think that's an important way to kind of frame things.
So it sounds like we've been talking more about acute pain, like like you sprain your ankle, you have a 6 out of 10, or you have a nail in your foot. And I know a lot of what I've dealt with is chronic pain. As an athletic trainer, we're trained to do acute, trauma. But as I've gotten into the real world, working with personal training, I'll have somebody come to me with chronic pain or something that's been bothering them for a long period of time. So is chronic pain kind of follow those same trends with acute pain when it comes to the subjective and trauma and historical, and just past experiences, and is that kind of the same scale?
That's a really good question. It depends on the person. So somebody you've worked with, we both worked with athletes. You work with an athlete who who is accustomed to having acute pain, acute injuries, acute meaning they just happened. They're within it's that day, that moment, within a few days. So somebody who has repeatedly sprained their ankle, or on a regular basis, like they're an MMA fighter, they get bruises and contusions and bloody noses and broken noses and broken ribs. Or I've actually had a lot of experience with ultra runners who their entire endurance athletes, they go into the pain cave and they live there and they know how to dismiss pain. And so those folks are going to because of their experience with pain, with acute injuries, they're going to respond in more of a dulling, dismissive way. And I'm sure that you've had plenty of experiences where you're on the sidelines and it's a big game and you've got an athlete who's clearly injured and they're saying, no, I'm
Don't take me out. Don't
put
take me
me
out.
in, yeah, put me in, coach. So you have that definition of pain. It's that emotional, and they have the sensory information, but they're interpreting it in the context of that moment and their beliefs and their values and what is important to them at that time. So it's all kind of the same but different. You just interpret it. It's kind of like the definition of pain. You interpret it according to that situation. And so somebody who the chronic pain is where was really the progenitor or the impetus for the research into pain sciences, because people who are in chronic pain have been underserved by the medical community, they've been abused by the medical community, they've been fed opioids, they've been cut into, they've been crippled, they have been really not treated well, they've been dismissed and diminished by people who are supposed to be helping them. And so that's the biggest thing with pain sciences, is it's validating people's experience, and it's allowing people like myself. When I was graduated from PT assistant school back in the early 90s, I remember hearing a lot of language from physical therapists that was judgmental and dismissive of people's pain experience. And that was back when chronic fatigue syndrome was a new thing, and fibromyalgia was considered to be a hysterical woman thing. There are still people who think fibromyalgia is a hysterical woman condition. She's just trying to get attention, that kind of thing. And that's where the pain sciences has shown the plasticity of the nervous system and how it actually changes in response to acute pain, but then also persistent pain. And so chronic pain, the more up-to-date definition is persistent pain rather than chronic, because it's a better framed term. It's it's less judgmental. It feels less permanent.
Right.
Your pain is persistent, but with a little glimmer of hope in there, like it can be. Just because it's persistent doesn't mean you're what's the word I'm looking for?
Like it's a death sentence. Like you're stuck with this for the rest of your life.
It's stuck with it for the rest of your life. Exactly. So I'm not sure if I answered your question or if I went on.
I know if you're with chronic pain for years and years, it might feel like it's going to be for the rest of your life.
Well, because it has been a big part of your life.
Yeah.
And so, folks who come in who have had, who've been in persistent pain for years and years, this is a good segue, let's talk about neuroplasticity. So here's my example. The nervous system, the central nervous system, changes in accordance to stimuli. If somebody is in persistent pain, emotional and sensory, which is an emotional and sensory experience, then, and including trauma, the nervous system turns its sensitivity up. Meaning, the best way I describe it is, if you're in a loud room and you're trying to watch TV, you keep turning the volume up. And that's kind of what that's my example of kind of what the nervous system is trying to do. That pain experience isn't diminishing, and so the nervous system turns the volume, turns up the volume, turns up the volume. And so the central nervous system, a person in persistent pain situation with a sensitized nervous system that has adjusted to being in that loud room, actually measures pain at a lower threshold than somebody who does not have that sensitized nervous system. So, and there are studies that have shown that have taken like a dynamometer and placed it on somebody who's not in persistent pain on their arm, and said, what number would that be for pressure, like 0 to 10 or whatever scale they're using, and then somebody who is in a persistent pain, having a persistent pain experience, and there's a marked and measurable difference between the two. And so that would be like, I'm a persistent pain person, you are not in a persistent pain experience, you would register the same pressure at a 2, I might call it a 6. That does not mean that your 2 is better or worse than it. The experience is valid and real. The 6 I'm feeling is a 6 to me. But the pressure is the same. It's interpreted differently by the nervous system because the nervous system is sensitized. So the discomfort that people are feeling, or the symptoms that people are feeling who are in a persistent pain experience, is valid and real. And what has happened is they have a sensitized nervous system that's giving them less than accurate data.
Okay.
And then the person has usually, and you probably also experienced, when somebody's in a persistent pain cycle, they have been messaged that their tissues are damaged. Their tissues are being damaged when they're having symptoms, and this is most commonly with low back stuff. That's where most of the bulk of the research is, because that's the bulk of, like 60% of primary care visits in the United States are for low back pain.
60.
Yeah, it's nuts. And then they're just given opioids and sent home. So nobody ever treats it. Yeah, it depends on where you live. But anyhow, and here's a random fact. It's actually not random. It's been proven. One of my mentors in the physical therapy world, Tim Flynn, he started his research based on this shocking revelation when he started living in Colorado as working in the private sector after working in the military. And all these people who were his age were coming into the clinic, and they were post-surgical for lumbar fusions. And he was like, his experience was he had never seen a lumbar fusion that had not been done, which is where the vertebrae are fused together or held together with metal implements to create stability. And he had never seen it outside the context of what the fusion hardware was created for, which was fractures from trauma, significant trauma, like Humvee accidents, car accidents, those sorts of things. He was seeing it used for just basic back pain, and found out that the most predictive variable for whether or not you're going to have a lumbar fusion in the United States, what do you think it is? Do you think it's your imaging studies? Do you think it's your symptomology? Do you think it's your function and your level of function, your strength? Any of those kind of objective measures?
Pain?
Yeah. Do you think it's any of those?
Is
Nope. It's your zip code.
It's your zip code.
Your zip code is the most predictive variable of whether or not you're going to have a lumbar fusion. And that's a whole nother podcast for sure. And that's a whole nother conversation, but regarding like the the over medicalization of persistent pain. And everybody at some point is going to have an episode of low back pain. If
Is
you
it
are
like a socioeconomic thing?
well,
Like, and the zip
insurance
code being,
companies make a lot of money from the complicated fusions increased significantly. There's a New Yorker article called "Knife in the Back," which talks a lot about this data from this whole situation. That's a whole another podcast in itself. But so we talk about the sensitized nervous system. I want to get to the homunculus and cortical smudging if we can.
Okay,
Can you put up the homunculus? So we talk about the sensitized nervous system, central nervous system, which is like a central nervous system which is like turned up. The volume is turned up, so it registers stimuli at a lower register than it normally would. The homunculus is the goofy looking thing. Oh no, not that one. This guy.
you did not send me that one.
Yeah, I did. I can.
Did you send me a fourth one? Because I only got 3.
Let's see. It's in there. I know. I tried to
Oh,
spell
it
it.
must have been 2. So, yeah, there's only 3.
We're gonna go to the homunculus in just a second.
Un momento, por favor.
Actually,
Actually, can you just bring it up? I can show it on. Oh, or can you send it to me? Whatever.
yeah, I just sent it.
Okay.
Actually, that other one you have has a little bit of the homunculus.
Yeah,
kind
that's what I thought.
Yeah,
That's
but I wanted to not distract people from the smudge, or by the smudge, as I'm talking homunculus. So, can they see that on there
No.
while you're putzing? Okay, that's perfect. So the homunculus is actually it's a schematic of the input, what's the word I'm looking for? The amount of input that your nervous system has, the nerve endings in different parts of your body. And so if you see underneath there, can you kind of use the pointer? Can they see the pointer?
No, they
If you
cannot.
hold it- Okay, so if you look underneath, the little squiggly pink things, the little squiggly pink lines, that's supposed to represent your brain and the folds in your brain. And so here we have, and that's the cortical part of the brain is the outside of the brain with all the lumps in it.
Mm-hmm.
So if you see here, look at how the face is really big.
Mm-hmm.
That shows that there are a lot of nerve endings in the face section of your brain. So each body part has a little place in the brain that is specifically for it. So you can see you have the face place, the face spot in the brain, you have the tongue spot in the brain, the larynx. Now, you don't often see this because if the genital area was on here, everyone giggles and thinks it's funny.
That would be
because
huge because it'd be a lot of pain, right?
a lot of nerve
Sensitive.
endings. A lot of nerve endings. And so a lot of the homunculus do not include the genitals because people are childish. But we have the face, the tongue, the hands, and you can see like the trunk has fewer and the legs. And so the two things to
Oh, the
appreciate
arm doesn't have
here.
anything, because I've gotten cut on my arm and never knew it was cut until I looked down and it was bleeding.
Yeah, your
That's
forearm,
interesting.
yeah. And so, and then this can be different according to your life experience. Like if you're a violinist, you're going to have maybe more in your fingers than someone else. But, so there's two things to take away from the homunculus, that there's a specific, discrete spot in the brain that represents every part of your body. And there is a difference in the number of nerve endings that are in different parts of the body.
So the tongue is more sensitive than the foot in this image.
Yes, absolutely. So it's important to understand this, and this is where that neuroplasticity kind of stuff comes into play. I just lost track of what I was going to say next. It had something to do the homunculus, the spot in the brain. So here's now the next kind of topic when we talk about like people who are having persistent low back pain and their central nervous system has sensitized and remodeled in accordance to that constant stimuli that is not providing a break. So you're in that loud room and the volume's still up, volume's up, because people aren't leaving, or the volume's not being turned down. So that stimuli is not being turned down, or your interpretation and understanding of that stimuli is not being turned down. So this next one, let's go to the cortical smudging. What ends up happening is that discrete area, that little discrete place that is supposed to be in a healthy, non-sensitized nervous system, let's say in this illustration here, the circle on the top picture, you see that circle is in the area of the trunk. The bottom area is showing that there is a discrete meaning like a small specific area that represents just the trunk.
Okay.
When the nervous system is receiving, just bombarded with this constant stimuli, and then you're emotionally interpreting it as something that is important and and alarming, and you're interpreting it as being afraid of moving, or that your tissue is being damaged, the central nervous system, the brain, actually goes from that tiny little spot that represents your trunk or your low back to having it be a region of the brain. And so this is actually really cool. Like for Adrian Lau's stuff is really, you can really dig in, go on
A region of the
YouTube.
brain and a region of the lower back? Or is that one the same?
The cortical smudging is a phenomenon that happens as a result of the neuroplasticity of the central nervous system. So the brain is constantly getting signals that are interpreted as tissue damage. In the context of a persistent pain person, their nervous system responds by turning the signals up and being more sensitized and giving more information about that event. That stimuli, and so eventually what ends up happening is you have, rather than having one, like let's say an eraser head. Do people even know what an pencil eraser is anymore? But anyhow.
What's a pencil?
I know, right? What's a pencil? Having something that's like the size of a pencil eraser, represented where your trunk is, your low back is represented in your brain. That constant bombarding and reordering of the nervous system creates it to be a region. So much larger area of the brain represents that area of the body. So if we look in this picture here, the bottom one shows sharp or in focus the pain interpretation, and so like if the check mark just says, okay, that person has pain or is feeling stimuli or symptoms right in that one little spot, and then if you look at the brain that is being represented by that spot, it's one little spot. Whereas somebody who's been in persistent pain and has had remodeling of the central nervous system, they have stimuli coming from the same discrete spot in their low back, but their brain is interpreting it as that whole region of the low back, so the whole low back, and because the area in the brain that is assigned to the low back has changed from being a tiny little area to more of a region. So it's gone from being like a city to a state in the brain. And that is why people who are in a persistent pain experience generally don't, their description of their experience is a little bit vague. They'll say my whole low back hurts.
Yeah.
It hurts across here.
Yeah.
And they were injured 2 years ago. The tissues take 6 weeks to heal. If it's been 6 weeks, the tissues are healed. And that's like a little bit more of a complicated conversation, but cortical smudging is really fascinating. So this is where, and I as a physical therapist, I can diagnose if somebody has a central sensitized nervous system, because there's normative values for what's called a 2-point discrimination testing, where you take something that's kind of sharp, like, and depending on how far apart those the 2-point discriminating apparatus is, because it depends on like the body part that you're using. So so when somebody has low back pain, they're going to be able to discern that whether or not it's whether it's two things or one thing. So if the brain at some point is going to be able to distinguish two stimuli, two sharp things, or they're going to register it as one sharp thing, but it's really still always two. So you just take it, you place it on the person's body part, and then the normative values tell you whether or not, if they're within that norm, then it tells you whether or not their brain is interpreting that city as a state, or that pain, or that those symptoms as sharp or out of focus, sharp or blurry. So for the back in particular, so normative values are 3 to 4 centimeters apart for the 2-point discriminators device. So I'll place, as long as it's in the same dermatome, but that's another conversation. So I can take the 2-point discriminator device, place it on a person's back and say, do you feel two things or one? If it's within the 3 to 4 centimeters, then it feels as though they're registering it as 2 versus 1, then you know that they have a sharp and in focus ability to interpret that stimuli. A person who has a smudged or regional understanding of their stimuli that's happening in the low back, you'll take the 2-point discriminator, and I've had people who've had something that is 14 centimeters apart on their back, like 14 centimeters. It's this far apart. I place it on their back, and they think it's one thing.
Wow.
Not because their skin is wrong, it's because their brain, the brain interprets anything that happens in that area as a discrete region.
Wow.
When really it's a big region. Their brain is smudged to the interpretation of anything that happens in that area. And so that's fun for me to be able to validate a person. I can do that 2-point discrimination test and say, look, you're outside. You should be at 4 centimeters. You should be able to distinguish that this is two things. Your nervous system is telling you that something that's 14 centimeters apart is one thing.
Wow.
That means your nervous system has remodeled, and it's hypersensitive, for lack of a better way of explaining it. I can track that objectively. I can retest that, and that really helps people understand, oh, I'm not crazy. It is in your head, but it's not in your head. Like, you're not hysterical and making up your pain. Your pain experience is real because your brain has remodeled. So cortical smudging is really fascinating, and if anyone wants to learn more about that, I would go to YouTube and Google or YouTube and type in Adrian Lau, ADRIANLOUW. He's a South African dude. He's super hilarious, really entertaining to listen to, but he explains a very complicated subject in a very understandable manner. And so one of the things, like, the central nervous system can get so messed up, the cortical smudging can be so profound, and he gets people who are very profoundly affected by persistent pain, one of his first exercises that he has someone do is before COVID, is take a magazine. If somebody's having pain, issues with their right hand, for example, he'll just have them circle the right hand in every one that they see in the magazine. And people who have significant cortical smudging and persistent pain experience can't even recognize a hand, which hand is right or left. And then there's a lot more we can talk about this, but it's a real thing and it's super fascinating.
Because I did CUs a while back, and I loved this one gentleman's presentation. It was like an hour long. I learned so many things.
Is it Adrian?
It was him.
Yeah. Oh, yeah. He's fantastic.
Yes, you're right. That
I've
was
seen
awesome.
him. Yeah, and I've seen it. He comes to the conferences that I go to. I've seen
Some
him
of the
live.
case studies he was using?
I've had beers with him. He's
awesome.
fascinating. Yeah, but it's really interesting. And I think for those of us who got into health and fitness and wellness because we're empathetic people, compassionate individuals, this persistent pain and the pain sciences gives us permission to have that empathy that we're naturally have, and allow us to do right not only by ourselves and our natural proclivity to be empathetic, but also to be able to have a tool through which you can explain things to somebody in a non-judgmental way, and then you can work with this. And so now the treatment for somebody like myself, who like a physical therapist, is graded exposure, and so you have to find ways for them to perform like somebody's got low back pain and they're afraid to bend forward. Then you're finding ways to frame the bending forward or moving their back in a way and reframe the context. So a lot of education of, look, the tissues are not damaged, your disc has been herniated for decades, it was never a problem, whatever it is, you do the education part, and then find ways for them to reframe that scary movement. And have them, and so graded exposure is in cognitive behavioral therapy. So if somebody's afraid of spiders, you bring a spider, first you bring the spider into the building, and you teach the person to calm down and lick salt or eat chocolate, or so to correlate something pleasant with that stimuli that they're afraid of, or that sensitizes their nervous system. And then you bring the spider closer and closer and closer, and pretty soon, and that's graded exposure. They're being exposed in a manner and to a threshold which does not alarm the nervous system. And so that's one of the things that the skilled physical therapist who's understanding in pain sciences will be doing. And that's something you've been into. You have had your continuing ed and you have an understanding of it as well. And I think there's probably a lot of people who don't have any of this training, but they've just kind of figured it out on their own. And the more informed you are with this, the better you can do right by your people. But you can also better collaborate or refer to and with other people who have more advanced training, who you can collaborate with, such as a physical therapist, because I can do it. If you get a persistent pain person in who's afraid to move, because we always talk about that permission to move, that's great, but you need to figure out how that moving needs to happen for that particular person. And so I can say, you do the thorough evaluation, explain the person about persistent pain, blah, 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 you're not injured, blah, 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 and then these movements are the things that you need to do. And so that graded exposure is the way then that you address the hypersensitive. So reframing.
So graded exposure would kind of be like the original physical therapy, for our ancestors. If we hurt our ankle, we didn't sit on a couch and ice it and watch Netflix for the next 2 weeks. We kind of hobbled around on it for the next...
because you had to.
Because you had to. So you were grading the exposure by doing a little bit more every day.
Yeah, and that's actually And then that's another term, is somebody who has coping behaviors, is somebody who does exactly that. And because of their life experience, because of the information that they have been given, they are not afraid of that. They can frame that sprained ankle in the context of a coping person, of and so you kind of bring to light that the American fear of any discomfort. And there was not how many amendments are there? 22? The Constitution?
26.
26?
Maybe.
There's not a 27th Amendment that all humans have a right, whatever amendment is, I'm sorry.
A right to
There's
what?
there's not an amendment to the Constitution that you have a right to live a pain-free life. As we age, pain and unpleasant experiences happen. You're going to get crickety. You're going to be sore. You're going to have recurrent discomforts that happen because you lived your life. We all have scars. The scars tell our stories, and so being afraid of those things really, and then the subsequent compensating movement pattern, weaknesses, blah blah blah, create forces that actually create new symptoms, new pain in different tissues, and that's kind of a consequence of a not coping mentality, and that's not judgmental. It's just if somebody who's a coper, who's going to walk around on that ankle, then I know that I need to be informing them a little bit more of I'm going to be their brakes. I'm going to be limiting them a little bit, telling them, okay, you do need to let the tissues heal, and here are the parameters that you need to use. Whereas somebody who's less of a coping personality and who is afraid of that injury or that pain experience, then I'm going to be doing a little bit more encouraging and educating and informing about the graded exposure, and reframing as another psychological tool. The cognitive behavioral therapy is reframing that experience and that interpretation, that emotional interpretation of that experience. And the most common thing that we do is, how old is that injury? Well, 2 years. Tissue heals in 6 weeks. Your tissue, you're not harming your back while you're moving that. And I'm just saying this succinctly. Some people you can just say it that simply with, but usually it ends up to be much more of an educational experience of just reframing that. When I feel the twinge in my back, it's not because of the original injury, it's because of the compensating pattern and the weakness that has happened because I've been laying on the couch eating Doritos for the last 2 years. So motion is lotion, movement is life. Yeah. And humans are complicated, and I'll just revisit again like how important it is, and we just had a really perfect example this week. I mean, it happens every week, at least once or twice. The importance of having a team that you're working with. You need to have a health and wellness team. One person cannot be everything, and if somebody is telling you that they are everything that you need for your health and fitness, then they are wrong. Straight up. There is no man is an island. No doctor knows everything. No doctor can do everything to the same high standards. And we all, everybody needs a team. You should have more than one person helping you out with and supporting you in your endeavors to live a healthy and active and enjoyable life.
Yeah.
So, any questions?
I had a you there, Frog? He asked me a question earlier about, he had complications from lead poisoning years ago.
Ooh, yeah.
I can't remember what the question was. Frog, you still there? Can you ask me that question again?
Oh, so that, God.
Let's see if I can find.
Lived in Flint?
I don't know how to find that question again.
Can you, I don't know.
I'm hoping he's still on.
Can you scroll? Yeah, you can always interrupt me. Like, Lord knows I'll circle back around. I'm going to circle back around to whatever topic, whatever tangent is there. The cortical smudging.
Oh, yeah, he's here. What was your question again about lead poisoning? Sorry, I couldn't find it from earlier. You got an expert at your disposal.
Well, it depends. That sounds a little bit medical, but
Yeah.
well, I understand.
Let's point him in the right direction.
Yeah.
Yeah, could you just copy and paste whatever that question was earlier? Let's see. Maybe I can find it on our. Does it save the? No, it doesn't. Thank you for staying on board too and watching. Yeah, I can't find your question from earlier. I don't know how to do that. I'm new to Twitch. For those of y'all watching on Facebook, we're also streaming to Twitch and YouTube all at once. He got lead poisoning when he was 18 months old and nerve damage from that. So
that's an interesting physical damage. Are you still experience? What are your symptoms
Well,
now? And
What nerve damage can mean a lot. So nerve damage.
26 now, and the nerves have started degenerating.
Which nerves?
Was that like a systemic thing, Frog, or was it specific areas?
And degeneration of nerves is. I'm not sure what that means. It could mean a number of things. But at the end of the day, the nervous system is plastic, meaning it can adjust. And if it is degeneration of the nerves, meaning, you've got a
Arms and legs.
Okay, so if you've got it depends on if they're peripheral nerves, it depends on if they're the nerves in the central nervous system, but your body can create collateral nerve supply. So let's say if this is a bundle of nerves here, bundle of nerves in your leg, and this one gets damaged and is out of the equation, these guys can sprout more. So you might have like an extra branch on the thumb that comes out to help where this one was helping. But that's a great question. It's not. It's something that's really hard to answer. Who are you receiving help from with regard to that diagnosis and treatment?
Yeah, things are a lot different in the developmental phases of our early life too.
Well, that's why lead poisoning affects children so profoundly, because they're developing. So I guess my main question would be, my primary concern would be, do you have a team, Frog, of people who are helping you navigate through that experience?
Interesting case study.
What does
For
he
sure.
say?
Lead inhibits the enzymes that Sean is chiming in on Facebook. He says lead inhibits enzymes that maintain cell membranes and DNA transcription. Thank you, Sean. Sean is watching on Facebook, and he is our resident soon-to-be Dr. Lynch. He's going to school right now for osteopathic medicine out in Colorado.
So, I mean, that's helpful to understand what is happening physiologically, but somebody like myself who looks at function and how somebody is living in their life, my question would be, are you in the care of someone who can be looking at you from a medical pharmaceutical perspective to address the degeneration of the nerves, and then also somebody who can help maintain function, because muscle strength and movement actually stimulates nerves and can stave off the effects of decreased nerve activity.
And Sean's also saying that the brain is the most sensitive to, so there's a lot of central nervous issues when it comes to.
Right. So it's a tough. It's really my main concern would be, do you have your team of people who are helping you? Because we can't diagnose or treat over.
He said he got a new neurologist. He said he's got a new neurologist, and was referred to a specialist, and that the neurologist he worked with up till now hasn't been a lot of help.
Okay, so then you need to find a neurologist. Anyone on your team, regardless of what it is, like if it's your health and wellness team, they need to be people that you trust and have a good relationship with. So if you don't feel like your neurologist is much help to you, then they're not much help to you. And so I would encourage you to find a practitioner with whom you feel that is for whom you get the opposite feeling from.
That's a great point.
So shopping around, and a lot of times a really good way to find support and information, and so that you can find practitioners who are more suited for your particular diagnosis is the online support groups. There's got to be somebody in your area who there's got to be somebody who knows somebody in your area who has a similar situation, who knows a decent neurologist, who knows a neurologist who can interact with you in a way that you feel like they are helping you.
Yeah.
But online support, so at Frog, are you in a support group for folks who've had lead poisoning as youngsters?
It would be a good resource, for sure.
But bottom line, if you've got somebody who's supposed to be helping you but you don't feel that they are, don't waste your time and money with them. Or is it worth your time and money to be continuing to beat your head against the wall and not be getting the help? Because that emotional experience can manifest itself in physical symptoms.
Oh, for sure.
If you feel like they're not helping you, do you feel like helping yourself? Nope. You know, we just be like, well, I guess this is just all that's going to happen. It can be easy to just kind of, sit on the couch and give up on the situation.
Yeah.
So I would encourage you to find, if you don't already have tap into the network, whether it's regional, national, and reach out to folks who have a similar situation as you have as far as a diagnosis, and find healthcare professionals who interact with you in a way that you feel like you're getting what you need, because that's critical.
Yeah.
Nobody should ever stay with a physician, no matter what it's your healthcare, and if don't feel like you're getting what you need, then you need to find somebody who will.
That actually presents as a question I meant to ask you, and so the stress of dealing with that kind of stuff, and I've often heard that stress can exacerbate pain, and
Absolutely.
And stress can actually manifest as increased inflammation in your body. So how would an inflammatory response increase your pain levels?
Well,
maybe not from a psychological standpoint, but actually physiological, because a lot of people that think that if I'm stressed, I have inflammation, my inflammatory markers are high, that's going to cause increased pain in my painful areas. So how does that all correlate in what you've experienced, or how you would explain that to somebody?
Yeah, so that just kind of goes along, that's a good question, that goes along with that neuroplasticity and the emotional and sensory components of the pain experience. Inflammation, I think, is a word, it's actually and Sean will say this, I will agree, it's actually a specific physiological response, and the term is used as a general term, and so I think I'll just kind of simplify it and just say that the stress causes an increase in stress hormones, which change your body physiologically and put you in a place where it can sensitize your nervous system.
Okay.
You are like a person, think about it, if somebody's stressed, and if you're super amped up and you're angry and you get a hangnail, you'll be like, ah, man, I freaking got about it.
So maybe,
because you're already,
maybe
your
it
nervous system
dials
already
the TV volume down, so you're more sensitive.
it dials it up.
But then, because you said if it's up, you have to speak louder.
When I'm talking about the TV, that's the nervous system. So
Okay.
meaning the nervous system is giving off more
So it's
more higher
hypersensitive.
Yeah, so the TV's louder, so the nervous system is louder. And so stress, and this has been proven, so it's less about an inflammation conversation and more about your stress hormones and how they attenuate in your sympathetic and parasympathetic nervous system, and how they make the pain, they lower the threshold for pain. So if you're chill and you're hanging out on the beach and you're doing the Jimmy Buffett thing, stepped on a pop top, cut my heel, had to cruise on back home. Does he sound super stressed? He's all like, cut my heel. He's chilling. He's got his martini. He's got his margarita.
Wasted. You don't feel anything.
And he's good, because he's chill. But if he's super stressed out and having a fight with his mother-in-law, and he cuts his heel because he's having a fight with somebody, and he's walking down that same beach, and he cuts his heel, it's gonna be this whole big thing. And so that's kind of
All right,
an example of how that pain experience, the sensory experience, but stress hormones make your body more sensitive.
Okay, so if I had an injury 2 years ago, I'm in pain, it's healed, and my doctor recommends drug intervention like an opioid or something, or a painkiller, how is that going to affect my pain levels? Like actually, what is that pill doing in my body to decrease my pain levels?
It actually sensitizes your nervous system and makes the pain worse.
So
opioids.
Is it just because I'm done, the pain is, I'm numb to it at that point? Because of, like, what is the thing that makes me feel better when I take that pill?
Well, it actually doesn't necessarily. So this is a whole nother conversation. Opioids were specifically created for short-term use, 3 days, post-surgical pain, or for end-of-life cancer pain. They were not created for chronic pain. So what has been proven is that chronic use or consistent use of opioids sensitizes your nervous system and makes you more sensitive to pain.
Okay.
And then you also have the addictive part there, so then when you try to stop taking the opioids, which really aren't helping your pain in the first place, then you have withdrawal symptoms, which are painful. And so it's this whole big thing. So opioids do not help chronic pain. They make your nervous system more sensitive and make that pain experience magnified.
Okay. What about muscle relaxers? I get that a lot. Like, oh, my
Okay.
back's spasming, I need muscle relaxers. The doctor put me on muscle relaxers.
Yeah, and so that just tells me that the physician is ill-informed with current evidence-based medicine, and they are, and that's what tells me. And they're not.
What would the use case for a muscle
so
relaxer
a muscle
be? When would that
relaxer-
be a good time to prescribe that?
Well, let's just go to the term muscle relaxer. So if you're going to give somebody a muscle relaxer, one would think that you would need to give it to a muscle that is not relaxed.
Right.
So if somebody is in acute pain experience, let's say they really spasm, they cause some tearing in their low back musculature, because that's usually the most common place that reason people get muscle relaxers. The muscles are spasming, and because the muscle can only contract if it gets irritated. It's the only thing it can do, and it gets caught in a feedback loop, and that spasm starts causing pain because the muscles are all. And so you give a muscle relaxer, and that muscle relaxer helps that spasm kind of reduce. So the judicious or correct use of a muscle relaxer is when you have a new injury that is causing the muscle to be not relaxed. It should only be used during that very acute phase for that 1 or 2 days where if you cannot stand up and cannot move, if you're crawling to and from the bathroom in your home because your back pain is so bad, then a judicious use of a muscle relaxer could be something that's appropriate for that person. But if you take a muscle relaxer for any time you have anything happening, because there are actually treatment interventions that are quite a bit more effective, non-addictive, and don't encourage you to lie on your back, because rest is not helpful for back pain. Yes, rest for 1 day, maybe 1 day. Within 24 hours, you start having loss of muscle mass, you start having dysfunctional motor patterns, etc. But if you're interacting with a physician and all they're doing is throwing you prescriptions for your musculoskeletal symptoms, then you need to go to somebody different.
Okay. We'll speed round, just asking you a lot, because things are popping in my head now. Heat for pain.
Heat is actually, this is another topic that I'm super a fan of. Heat is what your body needs to heal an injury.
Cool.
The whole rice thing has been completely disproven. It is helpful at times, just like an opioid or a muscle relaxer, during the very acute phase. So let's think about this. Ice is cold. When you place ice on the hot, swollen angry, brand new sprained ankle on the field or out on the trail or somewhere,
Right.
that is going to, the coldness will reduce the pain experience because of it's the analgesic effects. The cold reduces the pain just because it cools the tissues and dulls the nerve.
Numbs it.
It numbs the nerves. But it constricts the blood vessels, so
And they don't need
the blood is not getting to the area that is injured, and the way that an injury is healed is through blood supply, because all the white blood cells and the whole inflammatory process needs to happen in order to heal those tissues. So using ice when you have, for pain relief for something that's acute is physiologically appropriate, but the most potent effect, other than the pain relieving from the numbing, the most potent effect of ice is not when you put it on, it's when you take it off while the tissues are still cold. Because think about this, here's what happens. You've got that hot, swollen, angry, painful ankle, you numb it by putting ice on it, and the blood vessels constrict and things kind of settle. You get a little bit less swelling in there, but it's feeling better because it's numb, you can't feel it. And then you take the ice off while the ice is still cold and the tissues are still, the blood vessels are still constricted. And then what happens? Your body wants to warm that area, and so it flushes that area, opens those blood vessels, dilates those blood vessels, and it's like a fire hose effect. And that fire hose and just nourishing, beautiful, amazing red blood flushes through the area, flushes out the gunk and the byproducts of the inflammatory process which cause pain in the first place, and it just cleans everything out. And so leaving ice on for long periods of time and taking it for too long is not helpful. Okay. It's kind of like, when you eat a chocolate bar or a piece of cake. It's the first bite that's the most satisfying. It's the same thing for ice. It's that numbing part is where you're getting the most from it. And so people who put ice on prolonged, like those game readies and all that crap, after, especially if a knee replacement or a joint replacement or surgery, they'll be like, oh yeah, I left that on for 12 hours. They're like, great, now it's going to take 12 more hours for you to heal because your body has not been able to get the blood supply to that area. So at the end of the day, whether you use heat or whether you use cold, you need to do what you will do and like and enjoy. If somebody says you need to put ice on that injury and you frickin' hate ice, you're not going to use it, so you're not going to get any benefits out of it. So do what your body wants, but at the end of the day, if it's not a brand new, fresh, acute injury, or discrete, meaning you've got tennis elbow and it just really hurts right here, then you just do your ice massage to numb it, and then when you unnumb it, when your body's warming that up, it brings the blood supply to that area, which is a tendon that doesn't get a lot of blood supply. But it's peace and love is what injured tissues need, not rice.
Not shock and awe.
So the rice,
freezing to death.
Exactly, but that whole rice thing has been disproven.
All right, so all you athletic trainers out there listening, all my classmates that we learned about ice was, I think we had a whole chapter on ice, and then about this much. Well, we actually learned a lot about heat, but it seemed like it was just such common practice. And we were dealing with more acute injuries as well. So in the athletic training realm, ice is definitely going to be probably used a lot more, but general chronic pain stuff, throw some heat on there. And
and just understanding that science, the whole point to the scientific theory is to scrutinize itself and reprove itself or disprove itself. So people who say, who choose to not change their thinking, especially if you're working health and wellness or medicine, then you are not going to be serving your people correctly. So research takes an average of 17 years to translate into clinical practice. And I might be a little off with the 17, but it takes a long time to change clinical practice, and that is just not doing right by people. So peace and love is the new evidence-based recommendation for addressing acute injuries. So that would be protection, elevation, avoid anti-inflammatories, because anti-inflammatories actually interfere with the inflammatory process, and the inflammatory process is what helps your tissues heal. So people who are taking anti-inflammatories because they think that's going to help them heal faster, they're doing the exact opposite to their body. Their body knows what to do, like you're saying. You sprain your ankle back in the old days when you couldn't lay on the couch and take muscle relaxers. You let the inflammatory process happen, and your body's able to heal itself in the time frame that it needs to. So then we got protection, elevation, avoid anti-inflammatories, compression. But this is only for acute. And education, because one of the things, so the compression is helpful for an acute injury that has edema or swelling, because the swelling and edema, swelling is the components of swelling are the byproducts, are the garbage of the inflammatory process. The pH of that fluid is different, it's more acidic than healthy and healing tissues. That is what's causing the pain that you're feeling early on in the injury. Not the injured tissues necessarily, but the toxic goo of the inflammatory process that's stagnating in that area and causing pain. And so that's where the overuse of ice that does not allow for the flushing out of that toxic sludge of the inflammatory process is not necessarily, that is not serving your purpose as well. So early movement, heat, avoiding anti-inflammatories, allowing the body to do what it is that it needs to do well. And so now we go into love. So we talked about peace, which is protection, elevation, avoid anti-inflammatories, compression, and education, which is educating the patient about all the things we've just been talking about. And then love is load, optimism, vascularization, and exercise. So in the context of that sprained ankle, it used to be, oh my God, I've gotten medical professionals who've come in 6 weeks post an ankle sprain, and they can't move their ankle because somebody told them to stabilize it. You should be loading a sprained ankle to tolerance as soon as possible, moving the tissues gently. So load in a pain-free, gentle manner to help the tissues, because that also improves blood flow, and then it also encourages the body to organize the scar tissue in an organized manner. So going from that haphazard manner, weak, haphazard, and restrictive manner to a functional and healthy manner. So the scar tissue, as it's forming, needs stimulation to not be
remind it what it looked like before the injury.
It looked like this before the injury, and it moved, and everything was amazing. And then if you don't move while the tissues are healing, it just ends up to this clumpy mess. So load optimism, meaning the person needs to think to themselves, oh, my body's going to heal, I'm going to continue doing what it is that I can do, this too shall pass, 6 weeks, 4 to 6 weeks. Vascularization, so finding ways to, I was talking to a patient the other day, his knee had surgery, but somehow the medical professionals who are advising him are telling him that his whole body needs to rest. 1/16 of his body is injured. Why do you need to have the whole rest of you sit on the couch? I'm like, get on a bike. Cardiovascular activities increase your blood flow. What do? How do you feel when you get some exercise?
Feel good.
Yeah, you feel good. You got endorphins, you get the vascularization, meaning you get increased blood flow throughout your body, including the tissue that's injured. You feel better about yourself, you're more optimistic, your hormone panels reduce from stressed and a non-healing profile to a chilled out, stepped on a pop top, cut my heel, I'm chilling. I got this.
Phase.
And so optimism, vascularization, and exercise. And so that's a really good conversation. So the rice is fear-mongering and causing scar tissue, increasing the healing, the length of time it takes to heal, and scaring people and having them sit on their couch and eat Doritos. So rice is not a good thing past the first day or so of the acute injury. Whew, that was a good question.
Yay.
That was a lot of information.
Good.
That is
Got my mind working at the end
that
there.
is such a soapbox of mine.
Cool. Well, we went about 18 minutes over. Which-
Sorry.
It's okay. Tangent
We got to
Tanya.
talking. Tangent Tonya.
Well, thank y'all for joining us. If you have any questions, leave them in the message below, and we can get back to them. But otherwise, you can view this. If you missed part of it, you can go back and watch it after we've ended the stream. Everybody have your best day ever, and we'll do another interview in a couple weeks, and we'll announce the topic probably next week. So thank y'all. Have your best day ever.
Best day ever. Avoid the pop tops.
You've been looking there the whole time.
I know. Well, I forget. I know. Well, because I'm looking
Our
at
audience is
you.
there.
Well, because I'm looking at you. Wait. Well, then why do you put me over here? But then I'm here, but I'm still one of
That's
them.
it.
I've been looking at you. Well, you just tell me to look at that. Because that's one of the things with the
You were on a
problem is
tangent. I don't know what happens if you break a tangent. I don't know if
just
like the
point
universe.
at the thing. Just point at the thing. Problem is
Bye-o.
I'm there, but I'm still talking to you, and you're over there. So you need to.